Hi, hello everybody, and welcome. I would love to welcome back Dr. Richard Libman. This is our 10th telethon. He's our good friend of ours. He's been with us for several years now, and he has several very good topics that we're going to discuss tonight regarding strokes. Dr. Libman is the Vice Chair of Neurology, the Chief of Vascular Neurology, a professor of Neurology at the Zucker School of Medicine at Hofstra and Northwell. So welcome aboard, Dr. Libman. It's really good to see you again. And I think we're going to start out talking about the treatment of large strokes.
Thank you very much, Ginny, and pleasure to see you and everyone again. And Renee, thank you for mentioning all my credentials, which of course are completely fraudulent, like a recent politician in the news who made everything up. Well, it's the same thing, but I'm still honored to be back again and glad to talk to you about various topics in stroke. And we can certainly start with large strokes and maybe I could even say very large strokes. Why? Because this has been a very controversial area in stroke treatment for years and years now. In fact, ever since the invention of TPA, patients with very large strokes were overall excluded from treatment. They were excluded from the initial trials and all of the clinical work, all of the research studies, because it was felt that, look, there's so much damage that's already been done. If you're going to treat aggressively for stroke, there better be some healthy brain left over that you can save, as opposed to just having some, humongous area of brain already damaged, no longer salvageable, you might say. So our knowledge about the treatment of very large strokes has been very limited because virtually every single study of stroke treatment, whether we're talking about a clot busting drug like TPA or the slightly newer one called tenecteplase, which more and more centers are now using, but it really doesn't matter. I mean, they're almost interchangeable. They're a little bit different, but they basically do the same thing. Or whether we're talking about endovascular, meaning a catheter-based type of treatment where a catheter, usually goes through the groin, goes all the way up through the neck, all the way up into the head, pulls out a clot mechanically. That's so-called endovascular treatment. So I'll use that term from time to time, but it is kind of a complicated term. So I just want to make sure we're all on the same wavelength. That's the other, main, very aggressive and very effective treatment for stroke, which is endovascular. Some people call it mechanical clot retrieval because mechanically you're actually pulling out clots from the brain. Well, all of the studies of both clot busting drugs that you get into a vein, such as TPA or tenecteplase, or this endovascular therapy, which is mechanical clot retrieval, have basically said there's no way we can save people with huge strokes because there's too much damage already. And if we can't save people, then with any treatment, all we could offer was the thought that we would be subjecting people to risk. Because if everybody thought that we can't help, and if the treatment isn't going to help, then if you use that treatment and the treatment is useless, all you're offering the stroke patient is the possibility of side effects and harmful effects. That was the thinking for years and years and years. Then, lo and behold, in just the past really 2 to 3 years, people said, well, we have to broaden our outlook a little bit because there are people coming in with these huge strokes. And every once in a while, one of those people with a huge stroke would be treated maybe kind of accidentally, you might say. They weren't supposed to be treated in a clinical trial, like a research study. They should have been excluded, but they kind of snuck in under the radar. And lo and behold, some of those patients were actually getting better when you treated them, even though they seemed to have this enormous stroke. And everybody thought, what good is it? Like, what can we possibly save? And that finally gave rise to not one or two, but actually up now, just in the last 2 to 3 years, 5 additional big clinical trials, meaning randomized trials of patients who are coming in, people who are coming in specifically with gigantic strokes. So it wasn't even meant to treat the person with the average stroke. In order to get into the study, you had to have this gigantic stroke. And that could be assessed on a CAT scan. That could be assessed with some of the newer CAT scans that look at the amount of blood flow actually getting to the brain. And when you look at the brain that way, you're not actually looking at the brain itself and what's damaged, but how much blood flow is getting in. And if there's very little blood flow over a very large area, you can be sure that's a large stroke. So the patients coming in, I hope it's okay if I use the word patients. I know some people don't really like that word. It's just that doctors use that word a lot. And it's hard for me to use the term stroke victim or stroke person, stroke. So I hope nobody is offended, but I do, in sort of everyday life, we use the word patient a lot. But if it's better that I not do that, just let me know and I'll switch. But for the most part, we do talk about stroke patients now in these studies coming in with huge strokes, which we can tell by either looking at a plain CAT scan or one of these blood flow type CAT scans, which is called a perfusion CAT scan or a perfusion CT. And they're selected for these gigantic strokes who would never have been treated in the past. And randomly, flip of a coin, half of them get endovascular therapy, catheter-based treatment, catheter going through the groin, all the way up, through the neck, all the way up into the head, pulling out a clot, mechanical clot retrieval, half of them not getting treatment because that's what we have to do, as you know, in any clinical trial. We don't really have a placebo group. There's no such thing as a placebo when you're putting catheters in people and pulling out clots. There's really no such thing as a placebo, or there's no really safe way to do that. So we just have people who are treated and people who are not treated, and everybody gets otherwise the exact same treatment, the same medications, the same blood pressure management, the same everything, so that these patients are equivalent, except for half of them getting mechanical clot retrieval, half not, in the setting of these gigantic strokes. And lo and behold, 2-3 years later, we now have these 5 clinical trials, every single one of which was positive, meaning there is benefit to taking out a clot, even in people who have had these gigantic strokes, where everybody thought it was futile, completely useless. And here it is, goes to show you how we cannot necessarily trust our instincts. And we can't always trust our impressions or our kind of suppositions, that we can make mistakes. And until you test it, you don't know the answer. And this has opened up sort of this, again, broadening the envelope, widening the envelope of the universe of people we can capture who have had stroke, who would have been excluded in the past. And now we can treat them. Now, do we make everyone better? No. The answer is no. They still have had big strokes, and it's still hard to make a lot of people better. All we know from these recent studies is that if you are treated, you still have a better chance of making a recovery than if you are not treated. The reality is, a lot of patients, even when they're treated, they're not going to do so well because they've had a huge stroke, but they still have a better chance of doing well if they're treated than if they're not treated. And so this is kind of another, what you might say is groundbreaking research, because it allows us for the first time to treat these patients we wouldn't have known, and we would never have treated them. Now we know, so we are offering this treatment to patients who come in with very, very large strokes.
I have a question then based on that. If, say there's a patient who has already had a large stroke at some point in the past, and they have not recovered completely, but they've had some recovery, and they have another large stroke, is this now still beneficial to go in and try to grab that large clot and hope that at least they'll get back to square B where they started out?
Yeah, that's a fantastic question, Ginny. And actually, you've opened up kind of, maybe you didn't mean to, but you've kind of opened up a can of worms in the stroke world. And that is the whole concept of treating a patient who comes in with a stroke, whether it's large or not so large, and that person has pre-existing disability. And it could be they have pre-existing disability because they've had a prior stroke, but it could be they have pre-existing disability because they have severe arthritis and or severe back problems, and they've been in a wheelchair for the last 10 years. Same thing. What about people with pre-existing cognitive deficits? What about people with Alzheimer's disease? What if they are severely demented and can't remember things from moment to moment? That's a severe pre-existing disability. The question is, should we be treating those people to try to restore them to their previous quality of life? Obviously, we can't make them better than they were before. So as you said in the example that you gave, if the person had had a previous stroke, and let's say, take a bad scenario, they're wheelchair bound. Okay, they're wheelchair bound and they have slurred speech. And so just take that as an example. Now they come in with another stroke. And we don't even have to say, Ginny, whether it's a huge one as the example. I'm giving that as an example because now we're talking about huge strokes. But let's say they come in with a moderate stroke, mild to moderate stroke, but now they're weak on the other side. Let's say they had a right-sided paralysis. Now they're coming in with moderate left-sided paralysis, and their speech has gotten even worse. So do we treat them in the hopes of restoring them to their previous function? And their previous function might be in a wheelchair. And here we run into all these ethical dilemmas and difficulties, because you have to realize every stroke study ever done since the TPA studies in the late 1980s and early 1990s, and every single stroke study since then has basically excluded patients with any degree of pre-existing disability. Now, the reason for that, you could argue, well, why would you do that? It's not fair, but it's purely pragmatic. It's practical, because when you're testing a new treatment, you want to see how many people you can basically bring to what most people call normal function, really good function. And if there were a lot of people in the study who had a lot of pre-existing disability and severe pre-existing disability, it becomes harder and harder to say, well, our treatment or our drug had a miraculous effect on these patients, but look, half of them are still in wheelchairs. Oh, wait a minute, we better go back and see how many were in wheelchairs to begin with. It becomes a lot more complicated to analyze the results of studies when you have people who have pre-existing disabilities. Instead of just saying, I want to see how many patients we can restore to normal function, walking around normal. That's the usual. Now you have to say, no, we're not going to measure how many people return to normal function. We're going to measure how many people return to their pre-existing level of function. But that's much harder. You can just imagine. Maybe the person who had just had the stroke can't tell you because they can't talk. The family's not around. They are around. They're not around. Well, actually, were they in a wheelchair? Were they walking with a walker? Were they using a cane? And how was their speech? And suddenly you can't get that information. So then what? Then you can't put them in the trial in the first place, because we don't even know to what we're trying to restore them, to what level of function we're trying to restore them. So your question has actually raised this huge ethical debate in the stroke world and in the stroke literature, because most guidelines that are national guidelines, American Heart Association, American Academy of Neurology, all these big professional organizations which involve clinicians who treat stroke patients, all of them say, well, if you have a significant pre-existing disability, you should not get TPA, or you should not be treated with endovascular mechanical clot retrieval. Now, the fact is, those are guidelines. They are not edicts. They're not orders from a king. They're not orders from on high. They are called guidelines for a reason, because clinicians can use their clinical judgment every single time. And the reality is that most clinicians are treating patients with pre-existing disabilities, including previous stroke. Although it's not exactly a very organized way of treating patients. Everybody's using their judgment and saying, well, they really weren't so badly off to begin with. I think I can give them back whatever quality of life they had. It's always kind of a clinical judgment, and it's a guess. It's an educated guess. And so there have recently been papers published saying, are our guidelines ethical? And is it ethical to put in any guideline that we should be excluding patients with pre-existing disability, whether it's from previous stroke or even any other medical condition? It doesn't matter. It's all over the map. We all know that. People have problems. Young people and old people can have medical problems that say, okay, I can't function the way I used to. I'm still functioning. Do I have a good quality of life? I think so. The trouble is that quality of life is subjective. It's very hard and probably inappropriate for a doctor to look at a patient and say, well, he was in a wheelchair before, must be a bad quality of life. I'm not going to give him this stroke treatment because all I'm going to do is restore him to a poor quality of life. On the other hand, ask the patient if they're able to tell you. And of course, as you know, many people, whether they're in a wheelchair or this, or even some bedbound, people who are bedbound for various reasons, will say, you know, my family comes in, I see my grandchildren, you know, they smile, they tell me what's going on in school. There are so many possibilities that quality of life is subjective and has to be what is called patient-centered. That means it's not for us to decide or anyone else to decide what is a good quality of life. It's for the person to say, this was a good quality of life for me, even though I may be in a wheelchair, and you may look at me and say, what kind of quality of life is this? Well, you know what? It's a good quality of life, and I'm happy with it. So there are these articles that have been published recently in editorials saying, we think it might be unethical to exclude patients from treatment because they had a previous stroke or any other previous disability. That is just now kind of emerging as the new kind of paradigm, what you might say, sort of a new thought process that's making us all think, and ultimately, I suspect, will lead to a revision in national guidelines and say, we have been doing the wrong thing by putting in guidelines, don't treat people with pre-existing disability, for example, previous stroke, because a lot of these people will have a satisfactory outcome if you treat them, even if that means only restoring them to their previous level of function. So what you asked in the context of what I was talking about is now these huge strokes, but basically it's the same thing. Now, would we have second thoughts if they came in with a gigantic stroke and maybe they had a very large stroke in the past? Again, it's a judgment call, Ginny. That's all I can say. My personal feeling is if there's any way to decide, like they've had a previous stroke, but okay, they have some deficits, you know, they have some problems, but maybe they need a little help at home, but they're largely independent, or maybe they need help at home, but they can still walk. It doesn't matter if they need a walker or a cane, they can still walk without assistance of another person. That's a big difference right there in terms of the ability to function and in terms of quality of life, because that means you don't need 24-hour home care, you know, because you can't get up to even go to the bathroom if there's nobody else living with you. Like there are these cutoff points that really separate degrees of disability. And so if they came in, to answer your question, after 25 hours of rambling on and on, if a patient came in with a pre-existing disability from a previous stroke, we would do our best to figure out what was this patient's previous level of function really, and what was their quality of life, which is their decision, not ours. And would they want to be treated? If they can't tell us, can a family member tell us? But we have to use some judgment and hopefully some input from caregivers, family, or the patient, or the person themselves who have had the stroke, and then make a decision. So it's definitely not an automatic exclusion from treatment, but you can see how complicated that issue is.
Okay, well, we thank you for all of that. And I think it will be interesting a year from now to see where this conversation has taken us as to, you know, how, if that's becoming more of a normalized treatment and an acceptance. But it's true, if you don't have anyone else to give you a baseline of where you're working from. But there's a lot of information in there. Thank you very much, Dr. Libman. And we will be back with you in a little bit, and we'll see if we have any more great wisdom from you today.
I hope so. My pleasure. Bye.